This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Is there a DPC clinician, tech vendor, or industry champion that goes above and beyond to further elevate the DPC movement? Nominate them for a DPC Innovation Award to recognize them for creating traction, embracing innovation, and demonstrating commitment to the movement. DPC Innovation Award winners will be announced and honored at this year's Hint Summit, taking place in Denver, Colorado, September 27th through 28th. Nominate a DPC innovator at summit.hint.com, plus get $50 off your Hint Summit 2024 registration with promo code MyDPCStory. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Concepcion, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
The practice of medicine is in danger as third-party payers and administrators continue to set the rules and regulations on those of us who are actually providing healthcare. Many times these tasks have no bearing on clinical care of our patients. Health insurance does not equal health care. As they have been attempting to control the narrative, it's changing the way that many of us practice. As physicians, we have to understand and protect our asset and know our worth. It's our knowledge and our skill set that should be directed to patients and not wasted on administrative tasks and metrics. We talk about taking back the narrative. Well, when we say first do no harm, that's not only applying to our patients, but that should be a directive to ourselves. When I opted out of third-party payers, I stopped playing the insurance game and went direct. I didn't change how I practiced medicine. I changed how I interacted with the system. It empowered me, and it also gave me the opportunity to empower my patients. For me, the cornerstone of medicine is centered on the doctor-patient relationship. Accessible, price transparent, and with no middleman. For me, that is how you offer direct patient care. I am Dr. Grace Torres Hodges of Torres Hodges Podiatry, and this is my DPC story.
Dr. Grace Torres Hodges is a board-certified podiatric physician and surgeon who started Torres Hodges Podiatry in 2001. She then transitioned to a direct care specialty practice in 2017. She completed her undergraduate studies at Vanderbilt University and was pursuing graduate studies in sports medicine at the U.S. Sports Academy prior to medical school. Dr. Torres Hodges received her medical degree from the New York College of Podiatric Medicine and completed her postgraduate training in podiatric medicine and surgery at St. Vincent's Medical Center in Jacksonville, Florida. She maintains surgical staff privileges at her local hospitals as well as the Andrews Institute for Orthopedics and Sports Medicine. She has shared her knowledge with the next generation of physicians teaching the medical students and residents at Florida State University College of Medicine and the USUHS programs at Eglin Air Force Base and Navy Hospital, Pensacola, as well as within the Doctor of Podiatric Medicine Mentors Network. Dr. Torres Hodges has been named a top doc by Health Tap Online and was named the 2020 recipient of the FPMA's Podiatric Physician of the Year. Dr. Torres Hodges holds an executive MBA from the Quantic School of Business and Technology and promotes physician entrepreneurship. She is co-founder of D2P Medicus Consulting and remains a staunch advocate of preserving the doctor-patient relationship and the independent private practice of medicine. She has been featured on podcasts for Lean Frontiers, Healthcare Americana, and the Benjamin Rush Institute, and has been an invited panel member to Women in Leadership conferences. Locally, Dr. Grace is still remembered in her hometown as a musician and cellist with the Pensacola Symphony and remains active with volunteer organizations in her community. She is proud of her family heritage, especially the traditions and values her physician parents taught her. She was honored to share their immigrant story as part of the compilation book Filipinos in New York City. Above all, her most treasured time is spent with her husband, son, and daughter. Welcome to the podcast, Dr. Torres Hodges.
Hey, how are you?
Thank you so much for being here. And it is wonderful to start with such an impassioned opening statement. I absolutely love that. And I hope that the listeners are just ready to hear your story. So you are a podiatrist. You are a specialist who has been opted out of Medicare since 2017. But I want to take a step back. And if you can give a little bit more about your history as to after you graduated podiatry school, what did your world look like at the time?
So after podiatry school, I did my residency in podiatric medicine and surgery in Jacksonville, Florida at St. Vincent's Medical Center. I had a great opportunity there to learn about all aspects of podiatric medicine and surgery because, number one, we ran our own clinic. So there was something there to be said about actually considering private practice. So I was exposed to that. And then also, we were the only surgical residents at the hospital. So we scrubbed every case. I mean, I was scrubbing gallbladders and heart and everything. Never again will I do that. But it was nice because, you got to meet all different types of specialists. You got to learn different techniques from other people. You just interacted with the whole system at the hospital. When it came time after graduation, trying to figure out where to live, my husband and I actually were separated our first 2 years of marriage because he was still working in Washington, D.C., and I was in Florida. We racked up a lot of frequent flyer mileage back and forth and a lot of calling card calls all the time. But it was going to be either around the DC area or in Florida. I had an inkling of wanting to come back home to practice in Pensacola. Both my parents practiced there also. So I kind of had a little bit of a leg up to come back home. It wasn't that difficult to convince my husband to move to Florida. So I'm very grateful that he obliged and we did. So I started practicing in Pensacola. I actually joined a group first and was employed. And, I remember my parents saying, well, why don't you just open up by yourself? And then both of them, they have a general surgery and internal medicine, clinical cardiology background. And they wanted me to join them. I'm like, no way. I'm not going to do that. I grew up being Dr. Torres's kid all the time. And it was bad enough that I'd come home and even as a doctor already, they always knew me as, oh, are you Dr. Adelaide or Dr. Dewey's kid? So you always had to be kind of building up your own reputation on that, which again, that's another thing altogether. But I think it empowers me it empowered me at the time and made me, I have to do this right and do well. But I joined a group practice and I learned the intricacies of insurance capitation and contracting. Didn't realize that at the time when I signed away everything that I was in that practice. Actually, I didn't realize I was the one being assigned all the capitation stuff. So here I am working my butt off and was not getting a return because I had an associate to partnership agreement that was going to be based on the revenue that I was making. But when you're capitated, you're not going to make the revenue on that. And I didn't know that. Long story short, the relationship there ended after a year. And then I opened up my own practice. And I did not have one HMO or capitation plan in that. But one of the benefits of opening my own practice, I learned from my previous employer how to run a podiatry practice. But I also had a little bit of a leg up because my parents both had private practices already. They were actually in a joint private practice together. And so I I was free labor all growing up. I worked in that office. I answered phones. I filed. I cleaned. I even transcribed. So I learned how to, I was doing a lot of the transcription over there. But one of the things that it was a family business. Not only were my mom and dad the two principal physicians there, but my aunts actually were the office manager and the reimbursement and claims specialist. And early on, I don't even recall them being too much into insurance things. I remember when my aunt told me about the copay and how that was a different thing that they were doing. And, I was probably in middle school when all that happened. But, so I got to see the practice from both ends, from my mom and dad's side and also from my aunt's side, to see all of that. And so I had a little bit more business knowledge that I was able to take with me into my own practice. I successfully practiced from 2001 to about 2013, when I was feeling, the pinch of all the new regulations after having completed PQRS with Medicare, after completing a change up to, I started out with paper charts and then I had to switch over to EHR. I did the incentives with the electronic prescription because, none of us know that at the time, that what you end up doing is you're given a directive and said, you can get an incentive on your Medicare reimbursement if you do this upgrade to e-prescribe, without the knowledge, knowing later on that they're going to penalize you once you didn't reach or attain that by a certain date. But we were conditioned to just do this over and over again. And one day my husband was asking me, what are you doing? Come on, let's go. And I'm like, no, I've got to do my charts. I've got these audits to finish up, because there were probably some chart or audit. And he goes and says, you know what are you doing? You do this every night. And I said, but I got to. And he goes, but is it helping your patient? And then that little question right there was the one that kind of got me thinking. And then, is it really helping my patient? No, not really. It was going to help me get paid for helping the patient that I already helped. And then, it started the wheels turning a little bit on what am I doing? Why am I working so hard? And then each year up until 2013, I started, each year you had to see more people because your reimbursement rates kept on going lower and lower and lower. I had all the insurance plans. Like I said, I had no HMOs. So these are all private pays and Medicare, all PPOs. And you could feel that just overworked. And it's like, why am I doing this? You were just tired. You love what you're doing, but you just hated all the minutia that was around it. And then from that point, what happened was I got this email about this meeting called How to Thrive, not just Survive, from a group called the American Association of Physicians and Surgeons. And it was a one-day, all-day event, and you can get CMEs. And it was over in Dallas. And I really didn't know what to expect. I didn't know much about what the group was. And so my husband and I decided to fly out there to see it. And I get into this room, and the first thing that they talked about was opting out of Medicare. And I'm like, wait a minute. Why? Why would you do that? Who can do that? Especially me as a podiatrist. Why would I want to do that? That's 50 to more than 50. It was almost 75% of my practice. Why would I want to do that? But then I got to thinking, as I was listening to the lecture, about all of the rules and regulations, about the caps of how much you can charge, about the reimbursements, the punitive damages or the punitive penalties that are there if you don't do something right. And I got to thinking, oh my gosh, this is that. Yeah, they are right. That's exactly what I'm thinking. Why can't, yeah. And then they had a couple of other people come on and give basically case studies on their practices themselves. Josh Umber was one of them. And, to hear about Atlas MD early on in 2013. It was pretty still new, and it was amazing because these guys were young. They just got out of residency and they just opened straight up. And then ironically, I actually met 3 specialists at that meeting also. Dr. Kathleen Brown, dermatologist. She talked about her practice. Dr. Gerard Ginoli, an otolaryngologist, and he talked about that. And to hear it from a surgeon, that was really interesting. And then Dr. Chris Held, who's an ophthalmologist, to hear her. And then another doctor who's an emergency medicine doctor, Dr. Beth Haynes, went up and talked. And she was very, very passionate about explaining the importance of continuing on the noble profession of medicine. At the time, she was very much involved in the Benjamin Rush Institute. And that was my first encounter with the Benjamin Rush Institute, which, for those who don't know, it is a nonprofit organization that is geared towards educating our medical students and residents about free market principles and honoring the doctor-patient relationship. And that was probably the biggest thing that you get out of that conference, was that everything was geared towards the doctor-patient relationship. And it was kind of what, like my husband, when he asked me that question, is, what are you doing? Is it helping your patient? Everything kind of gelled together at that point, and then I made a commitment at that point to start really paying attention to my numbers. And we looked at the books. I looked at my payers. I knew who was paying well and who wasn't paying well. And then unfortunately, every year they got worse and worse and worse. But I decided to look at who was paying the worst and start weaning off. A lot of it also was educating. There was a group there called Docs for Patient Care that was really good about giving material to their patients, because it's not just doctors that have to do this. We are the first ones on board, but you have to also educate your patients about it. And I think that was the biggest thing in my transition from 2013 to 2017. I took that time to really educate my patients about what insurance and third-party payers were actually doing, not only to me, but to them, that they weren't being good stewards of their money. And by the time I dropped Medicare and opted out of Medicare in 2017, there's a method of doing it, but it was about 55% of my practice. I took a huge financial drop that first year and a half. But when you drop those people in there, a lot of them stayed on because they had been with me for a long time. And when I had already educated them about how the whole practice was going to run at that point, a lot of them stayed on. But when you did lose a lot of those first timers, that one, you have to be ready for that if you're going to go this route. I think in retrospect, if I was coming out of residency, I would have tried to do it directly. It is difficult when you're already in, I wouldn't say difficult. I say that it's more, you have to plan it properly when you're transitioning. Does that make sense?
It totally does. And Dr. T, had mentioned this in her podcast, but that you are so passionate about mentoring. And so when you mention, just being ready, it's definitely something that, to be business savvy, you have to prepare for the future. So I think it's very intelligent to mention that, because people who are new to this world of what is direct care, or could direct care work for me as a primary care doctor or as a specialist, that is something that they have to consider.
Absolutely. And the thing is that we want to do it well. Those of us that are in direct care, you want, for personal reasons, selfishly, we all want to do well. One of the things I think that's difficult for doctors, we're naturally altruistic and we want to serve people. But I heard a great phrase. I took the Hippocratic Oath. I didn't take a vow of poverty. And that was awesome when I heard that, because that's so true. We're running a business. When you're running a private practice, it is a business, and you have to start running it and thinking of it like a business. Your patients are your consumers, but there's just an added bonus to it, the fact that you develop a relationship with those patients. And that's the essence of medicine, is because there's that personal relationship that you get with them over there. But yeah, we want this to do well. We also want to attract good people into medicine. That's the thing. And the way that third-party payers and administrators have hijacked medicine by adding all these extra rules and regulations, it's burning out everybody. And you hate to say burnout, because that makes, you don't want to be the doctor should not be the victims of this, but it has tainted it. And the beauty of all this right now is that we have a chance to make a difference. So I'm hoping that my attempt in doing it by helping other doctors, by mentoring our young doctors, because, you know, when you get out, and I'm sure the same thing, you tell me if it's the same thing with you, when you go through school, particularly undergrad, you go through med school, your 4 years, and then you do your 3 years residency, some 5 years to 7 years, and then fellowship. First off, talk about just the undergrad through your first 3 years of residency. That's, you're talking about your 11 years of indoctrination of academic medicine. That's only in the hospital. You're not learning a lot. I don't know of too many programs that do private practices. That's why I was kind of fortunate with mine. We did have a clinic that we ran, but the majority of them now are all geared towards, particularly surgery residencies are all geared towards cases and in the hospital and trauma. But I'm sure also in the non-surgical specialties, it's the same thing. But again, you want to attract the right people into it. You want to make sure that you give them the opportunity to grow. And when you have some third party stifling you the entire time, that's not going to be helpful. But the students getting out don't know that. One thing, a statistic that I heard was that almost 61% of our graduating residents, they get interviews because they are catered to by hospital groups to join, the medical group practices. I don't recall that when I was going through residency. You had to find your job afterwards, but now they're actually recruiting them. Have you found that or heard that also?
Well, so in family medicine, I definitely would say that when I was graduating residency in 2015, most of the residents in prior years had all gone to Kaiser, because in Kaiser, Northern California, as well as Southern California, there's a lot of amazing deals. Like, we'll pay your 7-year mortgage, we'll pay your blah, blah, blah. You'll get this amount of money. But in terms of recruitment, I feel that recruitment was not that aggressive when I was in residency, but I definitely know that, having seen the recruitment side of things and heard the recruitment side of things in my local community after residency, I know that it's very, very competitive to try to get people, especially to certain regions where there could be lack of care in all specialties. Right. Yeah. But it's interesting, because when you mention this idea of that, that a person should be able to continue to grow after residency, and how you also mentioned the very regimented, we go to undergrad, then we go to medical school, then we go to residency, then we go to fellowship if we so choose. We're conditioned to just follow the rules. Our pathway is not designed for us to really think about how do we grow as individuals, not just in our skill set, but as making careers and choosing positions that allow for us to feel fulfilled in our souls, and for us to be able to have that freedom to develop the relationships that we want to build with patients. So I think it's so interesting how it all goes together. And I want to ask there, when you went with your husband, and in what profession is your husband in?
My husband actually has a health insurance background.
Okay.
The funny thing is that he's going to love this. He predicted this. He predicted a lot of this because he has a background in health insurance, having worked in the federal government before, and then also working in the private sector, having his own brokerage firm too. So he sees it from the payer side. So he was my office. He's still my office manager. He does it more part-time and away from it because he can do it remotely. But yeah, so he can actually see everything. A lot of what he did in my office was actually the follow-ups for reimbursement. And then when I stopped doing insurance, he didn't have a job anymore with that, which was, I think, maybe part of his plan in his head also. But no, but in all seriousness, his background's in that. He actually understood it, and he looks at it from an employer's perspective, and how the employer's money is being spent properly, and how the patient's money and the premiums are being used or not used properly. So, yeah.
When you mentioned, though, that your husband was on the opposite side of things in the insurance world, it's so interesting, because my question, not knowing what your husband did for a career, was, after you guys left that conference, the AAPS conference in 2013, what sense of value did you have, and how did it shift by hearing these words about wow, there's people, specialists, dermatologists, ENT doctors, people who are doing specialty care who are also probably very dependent on Medicare as the reimbursing insurance, that they're able to do direct care. What was your sense of value after you went to that meeting?
Oh, it went up. For the longest time, you think that after spending hours at charts, spending late days, seeing 30, 35 patients a day, realizing that the return on each patient was so minimal compared to the actual care that you gave, many times not being paid for your service until 3, 6, even almost a year after because of all the appeals and everything. The patient probably has already been discharged at that point and you still haven't been paid. Patients didn't know that. And unless you see the behind the scenes of it, unfortunately, a lot of doctors don't know that also. And that's another aspect of my mentoring is always trying to not teach just new doctors coming in, but doctors currently, what's going on in your office. And if you're working in the hospital or employed, you don't know what's going on. But that's the problem, is that if you don't know what the prices are of what you're doing, how is it that you're kind of contributing to the system also, to the broken system, unfortunately? One of the things I've recently started mentioning to patients is, because they say, well, why can't it just be like car insurance? Why can't health insurance just be like car insurance? And, and in a sense that people get it with car insurance. It's for major medical, for accidents. You don't see any of your car insurance folks paying for gas or for the car tire rotation or oil and filter changes, which are your maintenance things. Yet and this is going back to when my aunt was telling me about the copay and what was covered, automatically your annual checkups and everything. The fact that all those, it just got lumped into one copay. They think it was like a prepaid type thing. That's not how the system works, and that the cost of the visit was only $20. I know I think might be jumping a little bit around here, but as I'm thinking about what we're talking about, what's interesting is that the patient base that I had when I was still on insurance tended to be a lot sicker than the patient base that I have as a direct care doctor. And the reason being is because you're giving the patient onus on their own healthcare. They have to maintain and stay healthy. Otherwise, they are having to come in more often and pay more often. And they're getting value on what they're getting, their treatment. But look at the ones that only have to just do copays all the time. There's not an incentive, I guess, for them to get better because they're going to be taken care of anyway. I don't know if you've seen that in your own.
Definitely. My practice at this point is a few months old, not a few years old yet, right. But it's definitely that the people who came over from my previous practice really understand the value of health and the value of prevention. Right. And so it's very different when in my previous panel of patients, the people who would not consider a direct care practice are the people who are more so in the, I'm not going to do anything if my insurance doesn't pay for it. Like, right. I don't pay for healthcare. My insurance does. That, Dr. Jeff Gold is famous for talking about the credit card analogy, how, we just swipe our health insurance cards like credit cards. And it's like, it doesn't actually work that way because, Medicare premiums per month are over $170 this year.
What's interesting is that a lot of those patients and also the doctors don't understand how this works. Insurance will say, I'll pay 80% of your visit. Well, what's the cost of the visit? Because if the cost of the visit is $10, that's great. Okay. But if the cost of the visit is $1,000, they're going to pay 80% of that. You're still there's a hidden, that whole thing with price transparency and everything like that. When you don't know what the actual cost of the stuff is, you don't even pay attention. People wonder why the premiums keep going up and everything.
Mm-hmm. Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes. Now, I want to ask about your actual transition to, you mentioned it a little bit. You went back from the conference in 2013. You started paying attention to your books. You started paying attention to the reimbursement rates that insurances were providing you. And you started on this pathway of, I'm going to work towards not accepting insurance at all. And in 2017, you finally went Medicare free. You took a hit, you said, but I want to ask, when you knew that your practice is around 55% Medicare at the time that you decided to opt out, what did you do financially to plan for that hit?
So, at that point, then 45% of the practice was all cash already at that point. So, as you build the practice up and a insurance patient doesn't come in, there's another patient that comes into that slot. And keep in mind that your reimbursement on that cash patient now is better than what the insurance one was before, because you're getting paid for the full amount of your visit rather than only, the worst payer I had was down to 52%. You can't run an office. In 2014, 2015, our staff changed also, because as we started dropping insurance, my staff now consists of my husband offsite. So I don't count him. He's like half there, but I have two staff members. I have a front and a back office assistant. So your overhead, the things that you can control, you control. I got really, really picky about how I started paying attention to the ordering, making sure that we recycled all of our paper, because despite the fact that we had switched over to an EMR, we still use paper, but I really got strict on expenditures. I took out a line of credit. You have to be realistic with that. You also have to look at niches that you can do and look for non-visit type of things. Now in podiatry, we have a lot of options. Number one, we do surgeries and a lot of procedures in our office. Niches in there can include, I do minimally invasive procedures. I do a lot of nail surgeries. We do in the office, obviously, a lot of excisional biopsies, do it both in office and outpatient as well. I've always had an interest in, and I think it's because being a mom myself, podopeds, so there's a lot of that, and you start to market in that realm. And I didn't really do much marketing as much as word of mouth. I would show up at a lot of, my children's baseball games and their basketball games and everything like that. I'd sponsor the teams, I would check on the kids afterwards and everything. I would go to the preschools, to the daycares. I'd drop off flyers and introduce myself to the OBGYN staff. You have to do a little marketing on your own. So you find your niches. With that, I offer other modalities in my office that were already cash-based, that were never covered by insurance. Ironically, Medicare helped me a lot because they stopped covering a lot of services like routine care for nails, corns, and calluses. And what has always amazed me is like we'll take, for example, the diabetic shoe program, which Medicare has as a good program in the sense that it's there to protect the diabetic from developing pressure points with accommodative inlays and proper shoes, proper examination and everything like that, so that they don't develop an ulcer, eventual infection that could lead to an amputation. Good premise and everything like that. And that works. Medicare will cover that fully for the diabetic. 1 pair of shoes, 3 pairs of inlays, we're good. Now, what about if you have a rheumatoid patient that has severe arthritis with calluses on the bottom of their foot? That patient with Medicare does not get any kind of reimbursement for a shoe for them. Does not make sense to me. And it didn't. And in things like that, like I said, there were a lot of little rules and regulations that had nothing clinically to do with caring for a patient, that it made it very clear that you could transition. And the more I got into doing more cash things, private insurances are notorious for a patient comes in with bilateral or both side toenails ingrown and infected. They will pay for one and they will deny the second one unless you bring them back in for another procedure. Mm-hmm. I never did that. I never brought them back. You just swallow that because you don't do that to your patient. The most convincing one for me, and that led to one of my most vocal advocates for direct pay, was a gentleman. My diabetic patients come in regularly for a biannual checkup. So I know them. They are very, very proactive. This gentleman was very proactive, had nicked his shin, had a gash on his shin that had a little bit of an exposed tendon. I looked at it and I said, this is not looking like it's healing well. You should have come in sooner, obviously, but what's done is done. I want to bring you to the operating room. We need to delineate this, and I want to find out how much I might need to debride. I want to also double check and make sure it's not into the bone. And I was going to send him for an outpatient MRI to check this, but the insurance company denied it and said that, no, you need to do local wound care and put a cast on it. And I said, forget that. So I played the system. I sent him to the emergency room. I told him this also. And he was like flabbergasted. He goes, what? I mean, they denied it. And I go, it's a stat. I need it. And I go, well, this is how we're going to do it. Go to the ER. I gave him his note. I wrote a note to the ER physician, gave him a heads up. They ran the MRI at the hospital. They admitted him, consulted me, brought me in. I did the procedure at the hospital, but it got paid by his insurance. But even him, he looked at it. It could have been a lot cheaper had I done it the other way. And as time went on, more and more of those types of things kept on showing up. And by the time it was 2017 to drop everything, we were ready. And like I said, it took about a year and 2 months to build back up. And then since then, it's been good. The pandemic, ironically, showed how viable the direct care model works. Mm-hmm. Because when everything else shut down, direct care doesn't, because we're still accessible to our patients. Whether, I had an opportunity for them to come in and see me, but even before the pandemic, I was doing telemedicine. Because that's just for me, it's not a visit. It is an extension of the telephone call. It's the next phase up. I use it as follow-up for wounds. I use it for follow-up for nail surgeries, for triage also with the patient. Home visits, I started doing more of them because my patients were scared to come in. That's fine. I can do that. There's no one dictating us. And then I remember early on in the pandemic that a lot of other doctors were, how do we get reimbursed for the telemedicine? I'm like, not an issue for us, so that was actually a good thing. But I think COVID and the pandemic shutdowns all really did open up a lot of awakening with regards to direct care.
Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad. Yeah. And when we talk about patient awareness, I definitely would say, and we've said this on the podcast before, but it's so true that patients were sort of forced to see the ugly side of healthcare, and when they couldn't access physicians by their cell phones, their Zoom calls, whatnot, it made it very difficult for people to get care. And thus more people went to, at least in our community, local urgent cares, local emergency rooms for things that could have totally been taken care of in the clinic. But, this idea of like, how do I get reimbursed makes me think about how my husband, who is still in fee for service, he had, 3 no-shows on his last day of clinic this week. And I was talking with his mom and saying how like, oh no, he doesn't get paid, like that they don't show up. There's no codes to bill, or he doesn't get paid. Versus in direct care for physicians who are paid on a monthly membership basis or an annual basis or whatever the agreement is, there's no, oh, because a patient didn't show up, you don't get paid. And so, it's so interesting how if you could only talk to a person by telemedicine and fee for service, you may or may not get paid in the future. But with direct care, it's like, that's just included in the membership. So,
right. Bringing up the whole thing with that made a lot of patients aware, in the midst of all of those shutdowns, a lot of people lost their jobs and lost their insurance. Now, what do? And I was available for those patients because I didn't take insurance, so they could come and see me directly. And I think they were surprised to see how much, for a consult with a specialist, it's not as expensive as you think it would be. Everything is so inflated. And their mindset is so inflated because they don't know what the prices are. And the whole thing about price transparency, that became very apparent with it. And that's, the fact that their insurance was tied to their job. This is where the beauty of direct care actually in the free market works. Because if you are the owner of your own destiny, I guess, particularly not just from the doctor perspective, but from the patient perspective, you have the opportunity to go to who you want to go to. Mm-hmm. And when you want to go to it. Yeah. So it's the 3 A's: accessibility, affordability, and availability.
Yep. Yeah. And I love that. That's legit on my Instagram page for my clinic is the 3 A's. But when you talk about that patients, people who are in need of care can choose to go to anybody who is doing a direct care practice, because we don't discriminate against what insurance do you or do you not have. I go back to your mentoring and the fact that we need more quality physicians doing this so that people have access to people in their local communities, no matter where they live in the United States. So I want to ask about your mentoring, because people clearly have talked with you about direct care, direct specialty care, direct primary care. When you, as a practicing direct care specialist, have people approaching you, how do you start the conversation? The reason I like asking it like this is because I want to also plant seeds for people as they're talking to other people as to what you found is helpful when you have a conversation with someone who's interested in a direct care medicine, so that, we don't scare people off from that first conversation.
Right. I think it comes down to first remembering why you went into medicine. Okay. Again, we are naturally altruistic. If you go into medicine, do not go into medicine to make money. That is not the reason why you go into medicine. You go into medicine because you want to help somebody, and that you want to make a difference in their life. And to give is better than to receive. And that's the underlying premise behind it. So don't forget I guess it's Simon Sinek always says, don't forget your why, know your why. But that is the first and foremost. And what's going back to the fact that the indoctrination after 11 years of undergrad, graduate, and residency, at least for the first 3 years, what it took for us to get into medical school required all free market principles. We had to sell ourselves. We had to have that initiative to rise above. We had to know our worth, and we had to explain that to people. We had to show that to people. We had to see one, do one, teach one. We had to do all that. We have to remind people that we knew how to do that. We just forgot how to do that. And then you have to be realistic. You can only see so many people in a day. You're only going to see who you're only going to make money of the people that you can actually see, but don't work yourself to death about it. Be realistic. We get I think a lot of doctors in their head get spoiled because they get enticed by these big, and this is where I have seen some issues where it's been harder to transition out. Doctors who have already gotten on board big clinics or big like hospital groups, they had the big 6-figure salaries and almost 7-figure salaries in some cases, but that they got used to a certain lifestyle. And you have to be realistic. You have to just go back and realize that no, you work for each one. And just like balancing a checkbook, knows your ins and outs. It comes down to a lot of basics. It's a lot, it's not a harsh reality, but it's a reality that you have to. I try to be gentle when I explain that to people, because everybody's different. And I think my one of the key things that I do when I'm talking to doctors that ask me about direct pay and either primary care or specialty is that there's not a magic formula to do this. You have to figure it out yourself, but you have all the tools. I will help, I will guide, and I will be your sounding board, but you have to do it yourself. We all have the capability of doing this. And, look at other industries. My aha moment was when the plumber came to fix our toilet. What was so funny was that the whole way that came about made sense to me. Why can't a doctor do that? You go to your friends. In this case, I went on Facebook and I wanted to find out who do they recommend as a plumber. So you ask your friends, who do you recommend as a doctor? They come over, they examine, they diagnose, they give you your options. That's exactly what I do. I examine, I diagnose, I give the patient their options. I let the patient decide, just like the plumber made the client decide. You can either go with me or you can go to somebody else. It's always their choice. And then that's a key thing. You do have to remember it's the patient's choice. They're coming to you. And at that point, when I decided, okay, you fix it, you're the expert, go ahead and do that. The amount is transparent already. We pay at the end of the service. The transaction's completed. I'm happy. The plumber's happy. The same thing happens with a doctor visit. It seems so simple with it that way. And when you put it in terms like that, people get it. So I think it's just a matter of we may have overcomplicated so many things with the way that medicine is right now. But it was Josh Umber reminded me of that Pavlov quote. If you want to learn a new idea, read an old book. This is an old book. This is the way that medicine used to be done.
Yeah.
This is the way that my mom and dad practiced also, and it's ironic. I had a conversation with my mom today about this. And, one of the things that she's so grateful for was that I had lunch with both my mom and my aunt, the aunt that was the office manager. And so, she was so grateful for the fact that she got to just concentrate on medicine and didn't have to worry about the business end. And my aunt was the one that did all the business end stuff. And she goes and says, and I think what happened was the business people took advantage of you guys. And she goes, yeah, and now you're going to fix it. And I'm like, well, I guess so. Maybe I'm trying.
That's really beautiful though. And I love that it's full scope in terms of your parents now seeing you be part of this movement to take it back to how it used to be. So I think that's so beautiful. Now, when you talk to people about direct care, part of this is being an entrepreneur, and part of it is, the language of business and the language of owning one's own business. So how do you talk to people who might not have an MBA or might not have business training, or who might not have been in a previous profession where they were responsible for their own books, when you talk to physicians about doing direct care?
Going back to, we have the skill set, it just needs to be refined. Everybody learned how to balance a checkbook. So you have, at least I hope, so you know it. You know what's so funny is that you can relate it also to medicine. We understand ins and outs when it comes to volume in a patient, and ins and outs of your practice, the same thing. You have to, everything has to balance in there. We're all making sure that everything has informed consent. So I think that's important. Understanding how insurance contracts work and how they have not worked. read your contracts because you don't realize what you signed away for. One of the things that I mentioned to them is that just start slow, start small. And I actually have had a problem trying to teach business because it came naturally to me. And there are some people that are like that. It just comes natural to them also. So as a matter of fact, I went back to school because I actually had time now because the way my schedule is, I was actually able to go back because I wanted to learn the pedagogy of how to teach business concepts to people. I have a better understanding now in the midst of all of that. I think it's important that doctors that do understand business or have business degrees really speak up also, because it gives credibility not just within the physician world, but also in the non-physician world. I'm able to talk to other business entities, business heads about this, that I understand where they're coming from with it. The thing is also the whole idea of free market. It's going to take a community involvement. The physicians have to take the first step in this, but patients and their employers also have to understand that they're part of the whole ecosystem as well. But as more doctors become empowered and they break away from third-party payers and administrators, and then they open up their direct primary and direct specialty care practices, we'll have more people to educate. And then as employers find alternative ways to offer benefits that allow their employees to use direct care, that's going to be important, and not to be just going to just all the regular players, the major healthcare players. And then as patients, as they recognize and realize that the current health insurance industry, they are just not being good stewards of the money that they putting their premiums and so-called investing in it, and they'll find alternative ways also. But I think until it's going to take an effort with all of that. Like I said, with trying to teach the business aspects of it, it starts small.
And when you have conversations with people, whether they be in primary care or specialty care, what are some of the biggest fears that you hear people talking about? You've mentioned how to prepare if you're going to take a hit, if you're going from insurance-driven care to insurance-free care. But what are some of the things that you hear from the people that you are mentoring? Like, oh, I can't do direct care because...
I can't do direct care because I won't be able to, I have too much student debt. That's a big one. Again, that goes back to our conversation about, I think they get spoiled with the bigger salary, and then they got used to that lifestyle. You have to be frugal again. You have to live the life of a resident again. I don't know what it was for you when you were in residency, but we were making less than $30,000 in residency. So, and that was before all the time restriction things also.
And are you hearing any other major fears that come from either primary care or specialty physicians?
From the specialist, depending upon the specialty, I think with the DPC and your membership model, that's a little bit more financially secure in the sense that you've got that recurring stream of income. For specialists, that's where I was mentioning the fact that you have to find other niche services for it, because it's hard to do a membership in some of our specialties. I could talk about doing a membership for diabetics, but that's just kind of routine maintenance care. You wouldn't want to do that necessarily for wounds because you want the wounds to heal, so it's a little bit more difficult with that. And one of the phrases that I always say is that I didn't change how I practice medicine. I changed how I interacted with the system. So, when you put it a little simpler in that regard, I think that will help with the idea of switching.
That is an amazing quote. I'm big about writing quotes, things that are very meaningful. And that is one that I wrote down just now. That's just beautiful. Now, resources. I want to ask, because with you having your MBA, with you having been a physician in fee-for-service, direct care practice, what are some of the resources that you love recommending to other people when they're interested or thinking about converting?
Nowadays, compared to 2013, social media probably is one of the biggest ones. Your podcast is a big one. And there are several others also. Healthcare Americana is one, Entrepreneur MD, another one. There are organizations, the Free Market Medical Association, the Association of American Physicians and Surgeons, and hoping that they're going to have more meetings. I'd highly encourage everybody to go to those. And then now I think a lot of them are doing them virtually too. So there really is not an excuse for that. What's so beautiful about the community of direct care, everybody wants to help because it's a win-win for everybody. Ultimately, we're all going to be patients too. So we kind of want to see this work. There's no reason why we can't keep this going.
No reason at all. I love it. So as we close, I want to ask, do you have any other pearls of wisdom that you like to share with people as they're, jumping into this direct care space?
So one big one would be, don't get upset, particularly those that are transitioning. Don't get upset if a patient doesn't follow you or says something mean about it. A lot of times I had a couple of my patients tell me, you must be just doing this for the money. That must be all it is. You don't care about taking care of old people or anybody. Well, so what? To a certain extent, that goes to show you how they think of you, because they don't appreciate your skill set, your knowledge, your worth. They don't put a value to that. Understand that that's your asset. And that's what you're offering to them. And if they don't want it, that's fine. That's their choice. And with regards to that, one of the things that I was able to do once I started managing a group of panel that actually wanted to see me and would reimburse me at the rate that we could run the practice also, it freed up my schedule so that I could actually volunteer at our local community clinic. I'm I think I'm the only one at our clinic that's actually a practicing physician. The others are all retired, but we have a beautiful clinic that serves the needy and the uninsured downtown. I'm able to spend time there to give back because it's being subsidized by my patients that are actually coming in to see me. So I can actually help more people as a result of it. So don't get discouraged by the naysayers. They never were going to follow you anyway. And there's so many pluses to being in direct because of autonomy. You're getting full amount for what you're worth for your visit. And the time that you get to spend with the patient, you actually get to do your work properly. I don't understand how you can do an exam in 7 minutes. I just don't. There's no way you're going to get to know the patient. I recall watching my mom, she's the internist, and she would bring the patient after the examination in the exam room. She'd bring them to her office and they'd sit. My mom taught me a little trick all the time in the chart, and I still do it now. Always write one special story about the patient in their chart. So you'll always be able to remember it, and always write down their kids' names in the chart too, so that you can remember something personable about them, because that will help you also remember that patient. So little tricks like that. I remember her showing me that. My dad is a surgeon. He spends a lot of time with them, during the exam, and then afterwards, he loved to really make sure that he put things in people language rather than doctor language. And he would draw everything out. You don't have that time if you're going to be doing a 10-minute pre-op consult. So, there's, again, a lot of pluses, that the autonomy, the time with the patient, your time after work also. We have a life outside of medicine. I have children. I was able to go to my children's activities because I didn't have the weird schedule. I had because I could control my schedule. That's what it was. If I wanted to take a break, and patients understand it. That's what's neat about it, because patients, when you make a relationship with the patient, they get it. Even phone calls, a lot of people always say, I can't believe you give your cell phone to patients. I've been giving my cell phone to my surgery post-ops all these years. That's, 20, 21 years now. Have I had it abused? A couple of times, but really the majority of them, they are so apologetic. I'm so sorry to bother you, but that's usually the case. And now with the fact that we have email that's accessible on the phones, that's an easier way to even get a hold, because they understand it's on our time. But yeah, if you respect the patient's time, they respect your time also. So I don't run behind. My staff loves it. There's not a lot of extra paperwork, not a lot of waiting on the phone, for authorizations and other things. The coding, the fact that you can't, a 99214 for primary care and a 99214 for a specialist should be the same reimbursement. But in some insurance companies, that's not the case. That doesn't make sense. So there was a lot of nonsense with it. So I'm happy with what I'm doing, and I'm trying to convince more people to do it.
That's awesome. So what is the best way for others to reach out to you after this podcast?
So I am on social media. You can find me at Torres Hodges Podiatry or at Dr. Grace DPM. I am on Facebook, Instagram, Twitter, and LinkedIn.
Thank you so much for joining us today.
Oh, it was a blast. I hope someone gets what you always want is that you want one pearl to come out of this. And if somebody learns something from that, I am so grateful. And so thank you for inviting me.
Next week, look forward to hearing from Dr. Amanda Dornfeld of Sage Direct Care in Columbus, Indiana. If you've enjoyed the podcast and you haven't yet done so, subscribe today and share the podcast with a physician you may know who needs to hear about DPC. Please leave a 5-star review on Apple Podcasts and on Spotify now as well, as it helps others to find all these DPC stories. And if you haven't yet, be sure to follow us on social media. If you're wanting to continue learning more about DPC, check out dpcnews.com. Until next week, this is Marielle Concepcion.